Good evening, everyone. Good evening, dear participants. It is my pleasure to welcome you to the another webinar issued by European Society of Cardiovascular Radiology. My name is Maria Trigubova. I'm a radiologist from Mousseaux National Institute of Cardiovascular Surgery located in Kyiv, Ukraine. And for the next hour, I will be the moderator of the webinar together with Dr. Dominika Sucha from Utrecht University Medical Center in Netherlands. Hi, Dominika.
Hi, and good afternoon, everyone.
But before we start, I would like to thank to Circle CVI for supporting the organization of our meeting. Today we have the hot topic, Advanced MR of Cardiac Hemodynamics, and two great speakers. Dr. Francesco Santini will give us insights into basic physics, and Professor Elie Mousseaux, who will talk about clinical applications of 2D and 4D flow. So let me introduce to you our first lecturer, Dr. Francesco Santini, who is a research group leader at the University of Basle in Switzerland. After his master's studies in biomedical engineering in Florence, Italy, he got his PhD in biophysics in Basel in 2009. He currently serves as chair of the Reproducible Research Study Group of the International Society for Magnetic Resonance in Medicine and on multiple committees of the European Society for Magnetic Resonance in Medicine and Biology and ESCR. Before I give the stage to Dr. Santini, I also invite the audience to post your questions via chat and the Q&A functions anytime during both presentations. The questions will be discussed at the end of both lections at the end of the webinar. So please, Dr. Santini, you can start with your lecture.
Thank you very much for the kind introduction and for the invitation to this exciting webinar. I hope that I will repay your trust. Just give me a second. I'm going to share my screen. Okay. Thank you. Welcome, everybody. I'm going to talk about the basic physics of advanced cardiac hemodynamics, which will hopefully lead the foundation for the next talk today and the next talks in the future. So let's really start with the basics. I don't know exactly what your background of you as listeners is, but let's start with really the basic. What is an MR sequence? At its core, an MR sequence is a sequence of events that we control as operators or as programmers, and we start with our protons of our body aligned with the main magnetic field in this equilibrium state. In the excitation phase, we can dip our magnetization vector into the transverse plane. And then physically, this magnetization vector will then start to rotate around the main magnetic field in a movement that is called precession. What we are interested in is the decomposition of the magnetization vector into its transverse components and its longitudinal components. As you know, the transverse component will tend to decay towards equilibrium with T2, and the longitudinal component will try to go to its equilibrium state with a time constant T1. So this is all very basics, and this precession, as you know, will happen at the Larmor frequency. Let's go one step forward, because this will help us in understanding what happens from a physical point of view. So from our static point of view, which is called the laboratory frame, we see that our magnetization vector is doing a very complicated trajectory around the main magnetic field. Usually it's rotating like a spiral like this, because we have the one field during excitation, and also when we stop the excitation, it goes back also doing a spiral, basically in a similar way, of course, in the same direction. This is complicated to understand, because we don't understand spirals very well. So what do? As physicists, we put ourselves sitting on top of the B1 field, or rotating together with our magnetization vector at the Larmor frequency. So that if a spin goes at the Larmor frequency, so if it precesses at the Larmor frequency, we just imagine that it's just moving up and down in this plane. So it doesn't rotate around, it's just excites itself and relaxes. And this is very useful to visualize any process, and including the off resonance. Because what happens, this is our basic case. Our spin is now rotating at the Larmor frequency. So in the rotating frame, it will just be excited, and then it will just go back to its equilibrium state. And this only happens if the magnetization vector is at the Larmor frequency exactly. If the magnetization vector is not at the Larmor frequency, there is still a residual precession, so a residual rotation about the magnetic field. And this will cause not only this relaxation, but also this movement of the transverse plane. When we consider this movement of the transverse magnetization on the plane can be recorded at acquisition time in a parameter called the phase. Normally in our images, we see the magnitude images, which is the length of this vector, and the length of this vector corresponds to our T2 weighting or T1 weighting or diffusion weighting. But together with this, in any image, we also get our phase image, and the phase image is the plotting of how much this magnetization vector has traveled due to an off resonance. What are the sources of off resonance? So we know some of them. So there can be system imperfections, there can be tissue interfaces, endogenous contrast, for example, blood. We use it in susceptibility weighted imaging, implants. But now you say, okay, what does this relate? How does this relate to flow imaging or hemodynamics that we care about? Well, one important source of off resonance is the gradient. The gradients, you can imagine them as a tool to control the off resonance in a position dependent way. So we play the gradients the way we want them, and we generate an off resonance that is directly proportional to the position of each spin on the gradient. And this is how image encoding is done with frequency encoding and phase encoding, as you already know. But we can also use it in a very smart way to get into flow imaging, which is the topic that we care about. So let's imagine that we have a static spin like this. This is our tissue, and there is a spin that doesn't move. We apply one gradient in one direction. So this will create an off resonance due to this intensity at the position of the spin. So the spin will rotate as long as the gradient is on. When the gradient is off, the spin stops rotating because the spin goes to the Larmor frequency, and we know the Larmor frequency is in our rotating frame 0. So we then invert the gradient and play it exactly for the same time. This is the waveform. So we play the gradient with one polarity for a certain time, and then with the opposite polarity for the same time. What happens? whatever this spin had traveled in one direction, it will travel back in the other direction. So the final phase of this spin will be 0. Okay. What happens now if we have a spin that is in a vessel? So here we have our static spin, and this is a vessel that is flowing along the direction of this gradient. So this is a bit more complicated, but during the positive polarity, the spin will have traveled. And so it will not have experienced the constant gradient that was before. When we invert the gradient, now the force that was putting it back to its original position is weaker than the one experienced by the static spin. So we will have this phase difference. This phase difference is exactly what we care about. And this phase difference is easy to demonstrate, that is proportional directly to the velocity of the spin. So in practice, as you know, that there are other phase effects, so other phase inhomogeneity. In order to actually quantify this phase and to have it proportional to the velocity, we need 2 scans instead of 1, which lowers our temporal resolution. But this is not really a big problem. This is exactly the core. By looking at the phase, we have a phase that is directly proportional to the velocity. The velocity in this case is measured in the direction of the applied gradient. So if we have a stronger or longer gradient, we have a larger phase variation when we have the same velocity. And we have an image that is like this. If we measure the pixel intensity here, this will correspond to the velocity. An important parameter is the Venk, which is the maximum velocity that can be encoded with those gradients. Because if the velocity exceeds this Venk, then this is a phase value, this is an angle. And the angle, of course, a 180-degree angle is the same as a minus 180-degree angle. So when we exceed the velocity set by this Venk, then we will have some artifacts that we will see in a moment. Commonly, the velocity sensitivity is through plane, which means we are measuring the velocity that is going through this, in this case, axial plane. This is the aorta, ascending and descending aorta. Okay, so the typical sequence, we know that we have to add this gradient that is called a bipolar gradient. But of course, there are some sequences that are more adapted to this, and some are less. Typical sequence types are spoiled gradient echo sequences. Slice thickness is 5 to 8 millimeters. And we have usually a 1 millimeter square resolution or less. Venk for vessels is around this value. This is something that you can set. Temporal resolution is around 50 milliseconds, less than 50 milliseconds, and we will see it in a moment. So what can we actually measure now? So now we have done a single slice through plane velocity measurement. Well, we can draw an ROI here, and we can measure directly the velocity. We can find the peak average velocity, regurgitant velocity. If we just multiply this velocity by the area, we find something that is called, that is called the flow. This is the instantaneous flow. So it's velocity times area. And the flow is actually a very important parameter because it tells you how much blood passes instantaneously through the vessel. And it's rather insensitive to how we angulate the plane, because we have a problem here. If we have a plane that is perfectly perpendicular to the vessel, then we will only measure, we are only sensitive to the velocity that is going directly perpendicular to the plane. So this velocity is maximum when the plane is perpendicular to the vessel. If the plane is not perpendicular to the vessel, the velocity that we measure is a bit lower because we have some angulation and we don't capture the whole velocity. But on the other hand, we have a larger area here, so these two errors kind of compensate each other. And so we are more robust if we mismatch the angulation of the plane. This is the instantaneous flow. It's basically the same curve, but in milliliter per second. And then we can integrate, and we find the systolic volume and the regurgitant volume in a milliliter per second. So this is the area under this curve are now volumes and not flow values anymore. Okay, so these are the basic parameters that we can measure with through plane acquisition. But can we do more? So I just said that we are just doing a single slice 2D acquisition with through plane velocity encoding. We are not limited to that. With MRI, we can do 3D acquisitions. And of course, we can also encode velocity in an arbitrary direction. In this case, we can see that by adding gradients in different directions, one after the other, we can have a depiction of the velocity in the two in-plane components and the through-plane components. And this allows us to do something like fancy cardiac imaging visualization. This is the aortic arch. Or in this case, in neurovascular imaging, we can see the flow in the aneurysm. So we see that we have a richness of information. We have a volumetric coverage. We can do retrospective evaluation. We have isotropic resolution. So 4D flow is very convenient in many aspects. However, this requires always long scan times. We cannot do it in a breath-hold like we can do it for a single slice. And we have usually lower in-plane or temporal resolution. And then we might need to use a contrast agent because we don't have any inflow effect as we have with a single slice. But however, then we can do an analysis like this. This is from a paper. We see that we can put many planes. So from a single acquisition, we can do multiple 2D reconstructions. So we can plot vectors like we've seen before. And then we can also use derived parameters like wall shear stress. Wall shear stress is the drag of the velocity along the border of the vessel. And it's, for example, used for aneurysm and thrombi. However, we require very high spatial resolution for this. We can also measure something like pulse wave velocity, which is the time in which the pressure wave travels from one point to another. This can actually be done with a 2D acquisition, but requires a very high, proper, and possibly very high temporal resolution. Then other parameters are the kinetic energies. So to see how the velocities fluctuate and how much kinetic energy the blood has at some specific points in the heart or in the vessel. This is sometimes correlated with dilated cardiomyopathy, for example, but we will see it in a more clinical setup afterwards. Or finally, we can also derive some pressure fields. So when we have a stenosis, for example, we can see the pressure drop through a stenosis because velocity and pressure are intimately related with the Bernoulli law. So we can measure a lot of things. I would like to conclude this presentation in a few minutes by also mentioning what can actually go wrong and how we can properly set up a protocol for the velocity acquisition. So the first thing that can go wrong is, of course, related to Venk. I had already briefly mentioned it before. And if the Venk is too low, we are in a situation like this. So this vessel should be all white because the velocity is coming towards us. But we see there is a large black part that has an abrupt change between white and black. This means that the phase here overflowed. It went from a plus 180 phase to a minus 180 phase. This should be plus 185, but of course we cannot represent that because it's an angle. And so mostly at peak systole, we have this phase swap. This is called velocity aliasing. The remedy here is to repeat the acquisition. Something a bit more subtle is something related, for example, to temporal resolution. So this is something you decide before you acquire. And if you don't have the adequate temporal resolution, it's quite complicated to realize it and fix it. Because if you don't have the right temporal resolution, you might still get a good velocity signal, but instead of depicting correctly the peak velocity and the peak acceleration here, you have curves that are dampened like this. And these I refer to my paper that came out a couple of years ago, where we actually determined the optimal temporal resolution for a number of cases in the carotid arteries, in the femoral arteries and the aortas, depending on how well we want to depict our signal. And we see that before the general recommendation was a temporal resolution less than 50 milliseconds, and this is similar to what we found here. And finally, also some work that we did a few years ago what happens if we are in tortuous vessels? So when we do 2D acquisition, we know that we should have our acquisition that is perpendicular to the vessel. But, and especially when we want to measure the peak velocity, because we saw that the flow kind of compensates, but not completely. But we have the problem that in some tortuous vessels, for example, the carotid siphon or the vertebral arteries, the flow might not even be parallel to the vessel because the tortuosity will move it from parallel to the vessel wall. So in this case, I advocate that you can also think about something in between instead of doing a full 4D flow, which is the best depicting of all techniques that we have, but also don't do a simple 2D through plane flow. You can most of the time set up a 2-dimensional, 3-directional acquisition, which can be an alternative to classical acquisition. And we've demonstrated, this was already 2014, that it can be beneficial for measuring some complicated geometries. But unfortunately, it requires dedicated post-processing because the simple console that you have in your scanner might not handle this kind of data. Okay, this is basically everything that I wanted to tell you about the basic physics. Of course, there would be much more to talk about, but I guess you will be much more interested even in the clinical side of this story, which will happen in a few moments. I would just like you to remember that flow imaging is a robust clinical tool. The 2D acquisition is already widely used in the clinics. 4D flow is slower in acquisition, but is also rich in information. So if you acquire a 4D flow data set, you can then retrospectively measure a lot of different things that can give you a very complete picture. However, it's necessary to properly set up a protocol, and this means you have to choose the right bank, and especially with 4D flow, you have to use it to decide beforehand because you might not have time to repeat the acquisition, and also the right spatial and temporal resolutions for the things that you want to measure. Okay, with this, I conclude my presentation. I just wanted to invite you to an exciting workshop organized by ESMRMB. It's kind of a sister society in December. It's about open science in MRI, and it's called MRI Together. It's online and it's free for everybody, so I think it's a good opportunity if you would like to know more about MRI research. And with this, I thank you very much again for the invitation and for your attention to everybody. Thank you.
So thank you very much, Dr. Santini, for your excellent explanation on this topic and the invitation. And I just would like to remind all our listeners to please post your questions in the chat or the Q&A during the talks, and we will discuss all questions after the second talk. And now it's my great pleasure and honor to introduce the second speaker of this evening, Professor Elie Mousseaux from the European Georges Pompidou Hospital in Paris. And Professor Mousseaux is an active member of the Paris Cardiovascular Research Center at the National Institute of Health and Medical Research in Paris. And he has over 30 years of experience in cardiovascular radiology and has a very impressive list of publications that includes over 200 articles and several books and book chapters. And Professor Mousseau's research is focused on developing new post-processing softwares for estimating flow velocities and aortic stiffness measurements in various diseases, as well as valvular disease and heart failure. And his group also is developing new sensitive and quantitative methods to estimate myocardial infarcts, fibrosis, and cardiac function using MR. So in today's lecture, Professor Mousseaux will discuss the clinical applications of 2D and 4D flow MRI, as well as some novel applications of 4D imaging. So please, Professor Mousseaux, the floor is yours.
So I would like to thank also for the invitation, for this nice introduction. And I would like also to thank Francesco for this nice talk about the basic atmosphere for doing flow imaging in magnetic resonance imaging. So I have no conflict interest about this presentation. And the learning objective of this talk will be to be more familiar with functional parameters derived from phase contrast imaging, and to understand the difference between velocity and flow. This is very important. As soon as you compare the different methods for estimating the velocity, sometimes we don't appreciate exactly the same thing. So it's very important to distinguish mean velocity and maximal velocity, for instance. I will talk about that later. And I will illustrate the clinical application at this time for flow imaging. So I would like to be a little bit just in one slide to be back on the basic and to, of course, the VENC is very important because it's a way to avoid aliasing, but it's also a way to have more accuracy for what I call the velocity to noise ratio. If you take a very high VENC for avoiding aliasing, you will also have very poor velocity to noise ratio. So depending on what you are looking for, you must decide for your VENC. If I am interested by the velocity of the myocardium, the velocity will be between 0 and 15 or 20 centimeters per second and no more. So of course, because I know that the accuracy will be close to pi divided by 20. So if I want to have 1 centimeter per second of accuracy for the velocity, I will be obliged to take 20 centimeters per second for the VENC. But if I am interested by the velocity within the mitral valve, so I know that the velocity will be close to 120 or 140 for the maximum velocity within the mitral valve. So my VENC will be close to 160 meters per second, for instance. So that's very important to have such a point in mind. Another point, because I will discuss about the place of MRI. So MRI has to beat with echo. So that's very important to make what is exactly the difference between the two techniques. Of course, velocity can be estimated, and this is a reference technique. Ultrasound is a reference technique for estimating the maximal velocity. Maximal velocity means that within the vessel, you have a distribution of velocity, and you have at a specific part of the vessel, you have the maximal velocity. So because you have spectral distribution by using the echo, so for the maximal velocity, if you have as a well alignment of the direction of the velocity and the ultrasound, so the accuracy will be great for the maximal velocity. And when I speak about the mean velocity, when I speak about the flow, I mean at each point I have the velocity on the surface, and the mean velocity is the velocity average over all the cross section. So for the cross section velocity, the mean velocity or the flow in milliliters per second, the reference technique will be the MRI. Okay, so that's you must understand that's a point. Also for comparing the two techniques at this time, now it's well described in different papers because a different methodology has been used. Of course, we can compare and step by step the two technology for estimating the mean or the maximal velocity, as I said. But you can also use what I call the conservation of the mass, and I will give you an example in a few minutes. You can also study after modification of the loading condition of the heart, you can appreciate the difference between before and after a surgery, for instance. And I will talk about that for the validation of mitral regurgitation. And at the end, you can compare the two techniques by using the clinical outcome faced to a specific situation. Okay, and I will talk about that, for instance, also for the mitral valve disease. So, because of the previous talk, we can now discuss a little bit about the 4D flow imaging, because I really think that in the near future, everything will be done in 4D flow, because there is main advantage. The main limitation, as Francesco said, that the temporal resolution is a bit lower, but the spatial resolution, I mean, the whole volume is much better. And the main advantage of 4D flow will be that you can place exactly a posteriori after the acquisition, you will place exactly where you want by using reformat images, the section where you want, and you will appreciate the velocity and the flow rates at a specific location. The other advantage that because of a 3D acquisition in the 3D direction, for estimating the maximum velocity, you will take into account the three components. And as Francesco said, sometimes it's difficult because there is, as illustrated on the right plot on these images, you have a stenosis along the right ventricular outflow tract, and you have a chicane route of the flow. And it's very difficult by using ultrasound to be sure of the maximum velocity, because the orientation of the beam will be very dependent of the direction of the flow. And because there is some changing of direction along the length of the routes of the flow, it will be impossible by using echo to be sure to obtain the maximum velocity. This is why for all the pulmonary arteries, now MRI will be the best technique, the reference technique for estimating the maximum velocity and the flow during pulmonary regurgitation, for instance. And also the advantage, compared to echo, by using only maximal velocity, the maximal velocity is highly dependent of the underlying flow. You know, for the same stenosis, if you have different flow, the maximal velocity will be totally different. So the main advantage of 4D flow is that you can estimate the flow, the maximum velocity within the stenosis, but below or after the stenosis, you will be able to estimate the flow. And because the two are highly dependent, it will be a main advantage of MRI for that, okay? So that you have to think and to have in mind these advantages. So about the conservation of the mass. For instance, the main application of MRI will be to appreciate the velocity and flow within pulmonary artery and within the ascending aorta. And in normal volunteers and in normal patient with an absence of a shunt, you should have exactly the same flow. The amount of flow arriving at the lung is the same compared to the flow within the ascending aorta if you don't have any absence of shunt. So you can do the job by using the contraction and the difference in end-diastolic volume compared to the end-systolic volume for the RV and for the LV. And normally the stroke volume is exactly the same, okay? But you can also do the job by using the velocity, by estimating the velocity, and it will be more accurate, and has been well shown in many papers. So now the accuracy is around 5%. Normally the ratio of the pulmonary flow against the systemic flow is 1 plus or minus 5 to 8%. If you do the job by using the function, it will be 10%. So 20% it's not surprising in some way. Okay, so that's very important. So the main application for flow by using 2D, either 2D or 4D, will be the congenital heart disease. And the main application, as I said, is to appreciate the shunt analyzing, for instance. In case of right ventricular overload, because of a shunt, because you have a shunt between the left side to the right side, you have an overload by the volume of blood arriving to the right side. So you have a dilatation of the right ventricle. And in all these circumstances, you must look for a shunt at the atrial level or at the ventricular level. At the ventricular level, it's very easy because you have just to listen for the heart, and it will be easy to make the diagnosis. At the atrial level, it's more difficult. So we are using the small axis U as it is illustrated here, and you are doing short axis, and you must go up until to have the septal visualization. And as you can see here, there is a communication between the two. By scanning in another way, in this orthogonal view, I can describe here the septal defect at the inferior part of the septum. We call it the inferior sinus venosus. And by using the flow within the pulmonary artery and within the aorta, as you can see, there is a huge difference, and the pulmonary artery is the velocity on the flow is more elevated, and the duration is also much longer. So if you compare the two, you can estimate it that there is a huge increase of the pulmonary flow, and higher than 2, the surgery will be decided. It will be a percutaneous, also a percutaneous way. So that's the main application of that. And also for congenital heart disease, the main application is the fallow disease, because we know that the ultrasound is not so good for estimating either the stenosis and also the pulmonary valve regurgitation. So by using the 2D flow, you can estimating the flow within the main pulmonary flow, and you can estimate the flow during systole. We call it the forward flow. And when there is a regurgitation, you have the backward flow. Unfortunately, we know by experience for many years, we are doing the job for the last 20 years. And we know that sometimes, particularly when the pulmonary artery is dilated, you have another underestimation of the forward flow. So you have another estimation of the regurgitation fraction. So recently, we switch. We still are going to 2D flow, but we switch by using the 4D flow, by using an 8-minute acquisition before injection and before a delayed enhancement analysis at 10 minutes. We have the time at this time to do the 4D flow in free breathing, and I will be back on this and I will reply to your question concerning the acquisition mode. And by using the 4D, fortunately we are acquiring a volume. And as I said, you can do the reformate images, and you can be well placed by your anatomy guiding system, because you have the modulus image of this 4D flow, and you can help. You have fantastic images now by using the module after injection. So it's very easy to be orthogonal to the main pulmonary artery, and you can do the acquisition at this level. And you can be also helped by the direction of the flow. If you are using the modulus image as illustrated here, it's very easy to be perpendicular to the flow. So it's what we call a flow guide. And now we have a better experience by using the flow guiding system for being sure to be orthogonal to the main flow. And what we have done in fallow disease, we have a follow-up of patient before and after repair of the pulmonary regurgitation. And we have observed that we have a regression of a decrease of the end diastolic volume after the surgery. And if you compare 2D and 4D flow, we have obtained much better relation between the decrease of the end diastolic volume after repair by using the 4D compared to the 2D flow. So this paper is under submission at this time. For another main application on the left side will be, now I am talking about valvular disease. And the main application of the CMR is for, at this time, because it's not so complicated, is to study the aortic regurgitation. So by using a unique acquisition at the along the sinotubular junction, and a bit sometime for some people a bit orthogonal or to the ascending aorta, but I will tell you in the moment that I prefer to be at the junction. And you can estimate the flow and the positive flow, during the forward flow, and the negative flow. Of course, by using the software from Circle, for instance, you need to do what we call a zero correction to take into account the stationarity issue for being sure that there is no offset. Otherwise, you can do another estimation or underestimation of the regurgitation. So you have to take care about that. So what I would like to mention that you can estimate the forward flow, backward flow, and the difference is what I call the net flow. Okay, so this net flow even you have a regurgitation, will be the same in the pulmonary artery. Okay, so it's another, you can use a control if you want to be sure to avoid some mistakes. Sometimes you can also acquire at the pulmonary level for being sure that the net flow is the same, because there is no shunt. Normally the net flow is the same between the pulmonary artery and the ascending aorta. But unfortunately, because in some circumstances we have some vorticity, we have a dilatation of the ascending aorta, you have a bicuspid aortic valve, and the angulation is between your acquisition into and the direction of the flow is not so well placed. You have an underestimation of the flow within the ascending aorta. So we know that by experience. That's why so before going to 4D flow, I would like to mention that it has been well published since 10 years ago by Mousseaux, that by using such a technique, forward flow or retrograde flow, you can estimate the regurgitation volume. And as soon as the regurgitation volume is higher than 33 millimeters, you have a huge relation with the outcome of this aortic regurgitation. I mean, occurrence of heart failure, of surgery, and so on. So it has been well published, and this technique is well accepted. I mentioned some limitation of 2D in case of bicuspid aortic valve or in case of dilatation of the ascending aorta. That's why more people are using now the 4D flow. Unfortunately, there is not, it's because this technology is quite new, so there is some validation to do. So that's why we are doing some job in our center for trying to validate this technique in case of aortic regurgitation. And the main point was to decide where I have to do the measurement. Of course, as you can see here, you have axial images, and you have coronal images, and the sagittal images. So you are sure to be well placed by using the Eurofirmet images. And now I can place my quantification at different location along the track of the right ventricle, along the junction of the ascending aorta, at the sinotubular junction, or orthogonal to the ascending aorta. And what is exactly, is it the same result or not? This is exactly the same result in healthy volunteer or in people without any dilatation of the ascending aorta, without any bicuspid aortic valve. But in case of bicuspid aortic valve, we have shown recently that you can observe some difference. And now we have shown that it is much more accurate if I compare the stroke volume by using the cine. Okay, I have a stroke volume. And for the forward flow, it should be equal. So the forward volume by using velocity in either 2D or 4D compared to the stroke volume estimated by cine, it should be the same. Or by comparing the different result of the forward flow at different locations, we have observed that the measurement done at the junction at the annulus level is much better compared to the flow at the upper part of the ascending aorta, because in case of dilatation or in case of bicuspid aortic valve, you have vorticity and so on. So even in systole, you have some retrograde flow, backward flow within the ascending aorta during systole. So it's not possible just because of the vorticity. So for the forward flow, we now are convinced that it's much better to use the level at the annulus level. But for the retrograde flow, it's much better to use, so you can estimate also, you have a comparison. If I compare the stroke volume between the RV and the left ventricle, the difference is equal normally in theory, because due to the conservation of the mass, it's exactly equal to the regurgitation volume. So we have done the comparison at different levels, and we have observed that for the regurgitation estimation of the flow of the volume, it's much better to be at the track. So that's why now we propose, and in routine, now we are using a combination of the two, and we estimate the forward flow at the level of the annulus aortic level, and we estimate the regurgitation flow at the level of the junction, of the synotubulator junction. So now for the mitral regurgitation, sorry, the motion doesn't work here because it's too much place on my computers. But now it's well accepted that you have to do two things. You must have a small X-ray view series, and you estimate the stroke volume. And the stroke volume is equal to the volume during the ejection within the aorta, and also due to the mitral regurgitation within the left atrium. So if you estimate by using the velocity within the ascending aorta, you have precisely the volume within the ascending aorta. So if you subtract the stroke volume by the flow within the ascending aorta, you have exactly the mitral valve regurgitation volume. So now in routine, we can do that. And for instance, by using the CINE, we have estimated the stroke volume. By using the circuit software, we have estimated the stroke volume at close to 93 millimeter. By using the flow, we have estimated the net flow, because there is no regurgitation at all. We have here 60. So the difference is 33 millimeters. So the ratio of 33 over 93 is 35% for the regurgitation fraction of the mitral valve regurgitation. So it's quite easy to do. And by using such a technique, Gretzky have shown that there is a much more accurate result by using MRI compared to echo, because after the surgery, you have a decrease in the end diastolic volume, and this decrease before and after surgery is much more related to the CMR number for the mitral valve regurgitation quantification compared to the result obtained by echo. And unfortunately, at this time, we realize that, and it was well shown in this paper, fantastic paper, I encourage you to read, that there is another estimation of the mitral valve regurgitation quantification by using echo, and a lot of people are sent to the surgery without having a real severe regurgitation. So that's a main problem in routine. The next subject is how to estimate the diastolic function. For the systolic function, as you know, it's quite easy. We estimate the volume, and the systolic function is decreased when you have a dilatation of the left ventricle, and when you have a decrease of the ejection fraction. So the flow is not so important. But for the diastolic function at this time, we are using echo. And very simple, in a simple way, there is a lot of different parameters, but one of them is to estimate the maximum velocity using echo, during the early filling and during the atrial contraction. And you can make the ratio between the two for estimating the E over A ratio. But you can also estimate the myocardial velocity. And if you have a huge increase of the ratio between the maximal velocity of the mitral flow compared to the myocardium, you have a diastolic dysfunction. So it's quite well validated system, and we have compared by the result obtained by using 2D flow, and we have obtained exactly the same result. Instead of, we are not using the maximal velocity for the early filling and the late filling during the atrial contraction. We are using the flow because MRI is much more accurate to estimate the flow compared to the maximal velocity. And we have done a lot of comparison, and the results were very close from result of echo. But if you look the relation between the age, for instance, as you know, as more in elderly persons, you have a decrease of the diastolic function. And the relation with the aging was much better by using MRI compared to echo. So we feel that the data were very accurate. So now we switch also for the diastolic function by using the 4D flow, and we can estimate the flow within the ascending aorta, within orthogonal to the tip leaflet section, and we have also done during the diastolic filling, you have a posterior displacement of the mitral valve, so you can also do the measurement at the annulus level. And by using dedicated software, now we can also use the maximal flow within the ascending aorta by comparing only the two different levels of the mitral at the mitral valve level. And if you compare in healthy volunteer the mitral filling during the diastole and the ejection and the flow during the ejection, this is exactly the same in normal volunteers. So we are satisfied by our result, and then we have done the comparison between the two technology, ultrasound and MRI, and both of them found some very interesting comparison between the age, as I mentioned before, by using the 2D. We have done a paper in 2D 5 years ago, and we recently published in 2021 the result of 4D, and the relation was very accurate by using the 4D flow. And instead of 2D, the relation by also the LV remodeling, as you may know, as soon as you have a hypertrophy of the left ventricle, you have a decrease of the diastolic function. So in healthy volunteers, the more remodeling you have, I mean a small area, a small cavity, and a bit increase of the left ventricle. So you have the relation between the remodeling and the diastolic dysfunction was much more accurate by using 4D flow compared to 2D flow and compared to echo. So we were satisfied about that. And now, if I apply this with aging also, it will be also very interesting. And when you do some comparison, for instance, if you look for the peak filling flow that we normalize by the filling volume, this is the main, sorry, I will be back a little bit here. So for the diastolic function, now it's very easy to do. We only use the peak filling ejection filling rate, and we normalize this peak early filling rate by the area under the curve, and this volume is called the filling volume of the left ventricle. So we just do the ratio of the peak early filling rate to the filling volume, and we have done this in 2D, and it was very clear, it was very accurate for distinguishing patient with aortic valve stenosis from healthy volunteers. It was very accurate to do that, as exactly comparable to ultrasound. So we published that many years ago. So for closing this session, I will just briefly talk about pulmonary hypertension. So at this time, I just only mentioned velocity, mean velocity, and volume, and also forward flow, backward flow, net flow, and that's it. By using more sophisticated indices, but more complex, and we need some more validation, you can estimate it, for instance, the vorticity. So it's more complex because you have to do derivation of the estimate of velocity in 3D and so on. But writer, for instance, have found a very fantastic relation between the flow, the duration of the vorticity during the systole and during the whole cardiac cycle. And the more long is the duration of vorticity, the more elevated is the pulmonary pressure. And as you can see on this plot on the right-hand side, it's very impressive to see the relation between these two index. So we need some confirmation by using other paper, but it would be very interesting in the next futures. Another main application will be to estimate directly the pressure gradient. As you know, at this time, we are doing a lot of assumption in echo or also in MRI by applying what we call the Bernoulli equation. But we are doing the assumption that there is no change through time of the velocity. So we know that it's totally wrong, but this is the Bernoulli simplification. And by using the Navier-Stokes equation, now we are now able to directly estimate what we call the pressure gradient. That means a relative difference of pressure in space. And for instance, in this coarctation, in the future, we will be able to estimate directly the pressure difference between the ascending part of the ascending aorta and the descending aorta. And of course, we will have the pressure gradient and the flow, because in case of a lot of circulation, the flow within the stenosis is not so high. So in this case, for instance, at echo and at MRI, the pressure gradient was very low. But because we know that the flow was totally decreased within the stenosis, we know that this stenosis was severe because we have both pressure gradient and the flow. So in the near future, it will be very interesting to do the difference. And the main applications will be aortic valve stenosis, but we need to go further for having more validation in this area. But do not forget that we have velocity, flow, and both. That's fantastic. Instead of having only the maximal velocity, we know that there is a severe aortic valve stenosis, but because we have low gradient, because we have low flow, low gradient. But if you have exactly both, the gradient and the flow, it would be very interesting to study. So I would like to conclude that now flow is essential in CMR. We are using flow, we are doing more than 2,000 heart studies per year in my institution. We are doing flow in more than 50% of the case, mainly for congenital heart disease, but not only. Now for many cardiomyopathy, because the diastolic function will arrive, so we should do a lot of flow measurements in the near future for everything. So it will be like in Doppler and echo. You are using flow. As soon as you are doing ultrasound, you are using the Doppler during an ultrasound examination. It will be the same in the near future for CMR. I am sure of that. It will be a question of time, and that's it. And the question of validation. But at this time, for aortic valve and mitral valve disease, we now require an MRI because we are not sure of the echo data. As soon as there is some discordances between ultrasonic indices, MRI can be invested in these two main applications for valve disease. So, of course, it's, as mentioned before, it's very important to choose the vein to avoid aliasing and to have a very high velocity to noise ratio. And I have tried to convince you that you need to understand every parameters, very simple way. Forward flow, backward flow, net flow, feed volume, PEFR, PAFR, difference between velocity and flow. You must have in mind. And then you will have other sophisticated flow by using flow tracking, velocity, loss of energy, and so on. Pressure gradient, it will be for the future. But at this time, flow, velocity, and that's good enough for many, many applications. And I believe that it's underused at this time. Another limitation of MRI will be to do a very accurate correction, what we call the eddy current effect. I have no time to discuss about that, but it's a very important point because at this time we are waiting in 3D to have an automatic way to erase the error of velocity estimation, and it can be a nightmare at this time. So we need to improve a little bit at this point. And I have tried also to convince you that the 4D flow in the real near future will replace the 2D flow because it's a fantastic technique. The main limitation is for the temporal resolution, but by using what we call the view sharing and so on, I am able to have velocity at this time in my center in every 25 milliseconds. So that's good enough for estimating the mitral flow with a peak. It's very, very simple to do, and the end estimation is very low. So thank you for your attention. I have some back slide if necessary, depending on your question.
Thank you very much for your excellent lecture and for showing us how to use 2D and 4D flow in clinical practice. And I completely agree that 4D flow is a very promising and helpful technique. And we are limited by the time tonight, but I'm sure we could discuss for several more hours. I would like to ask you maybe both some questions in the Q&A. maybe what most of our listeners are wondering is what are the best patients or cases to use 4D flow, or when to recommend to use 2D or 4D flow, also time and effort considered?
In my experience for congenital heart disease, at this time we are scanning 4D flow for all patients, because it's much easier to use a free breathing technique. In a few minutes, we can now have enough very accurate result by using between 7 and 10 minutes of acquisition in free breathing. It's very simple, because if you ask for the tech to have a good positioning of the 2D flow, it's sometimes very difficult to be sure of your position. So the main advantage, you can do it by your own after that. And another limitation is the time process for doing the processing, but it's now the software will be more accurate, and in a few minutes you have all the results you want. So I will say, of course, we need some more validation for sure. We need some more validation, but for congenital heart disease, it's done for pulmonary regurgitation and so on. So I really think it's a good application. And now we are still using also 4D flow for the ascending aorta, because I have done a lot of mistakes by using 2D. I have done a lot of mistakes. Sometimes it's not possible. When the net flow is so low, because you have the forward flow, you have underestimated the forward flow. I don't know why people are not saying the truth in papers, because I know that I have used 2D flow for 25 years now. So I know that in case of dilatation, you have an underestimation of the forward flow for sure. So it's better to be in the left ventricular outflow tract or at the annulus level, where there is a convergence. And now I have a huge difference between 4D flow and 2D flow, and I trust my 4D flow result compared to the 2D. That's my experience. It's not well validated and recognized, but in my experience, it's much better.
Yeah, I can also concur that congenital heart disease, it also gives you a very nice qualitative evaluation of the clinical situation of the patient, and also for future surgery planning. This is really valuable for the flow information.
So I can imagine a lot of our listeners are actually now maybe just setting up the 4D flow MRI for clinical practice. And as we know, as with any new technique, it's important to get familiar with the technique and the post-processing methods and the images. So do you have any advice when setting up the 4D flow MRI, like what cases to start with or how to get familiar with this technique?
Yes, my advice will be to first to take experience with flow by using 2D, because it's simple. But as we are talking about the limitation and so on. So now, of course, when you are in a trained institution and so on, by using a lot of cases, now we have a fixed acquisition system and so on. So we trust our data because we are doing form 2 and so on. So of course you need some experience, but you should start by using 2D and then try to switch a little bit with 3D. And then when you have a good concordance, when you take more and more experience, you have a dedicated software by using Circle or whatever is a software. We need some training. You need some training, of course. But after that, that's why I also insisted to the way to validate in your own center. To take, in case of aortic regurgitation, normally my pulmonary flow is the same compared to the net flow is the same between the lung and the ascending aorta for the net flow. So if it's not the case, you have a problem by using 2D or by using 4D and so on. So you need to do your own validation, to take your own experience and then to see what's happened, where are the problems and so on. Of course, if you don't have enough, because there is some difference between MR system, you can have also some difference in accuracy for the sequence, and there is also some difference due to the software. So it's complicated. You need some standardization, you need experience, but at the end it will work.
Okay, thank you. So I would like to ask one last question from the audience. There's a question about the stroke ventricular volumes that are usually 10 to 15% higher than the aortic stroke volumes, also in patients with no mitral regurgitation. Is this something you also observe?
No. This is my way to be sure about that. No, so now the difference is a few percent, no more than 5% difference between the two in healthy volunteer. And in case of aortic regurgitation, if you look for the forward flow, and in case of aortic regurgitation, my way to validate is to compare the stroke volume by using the CD and the stroke volume by using the measurement within the ascending aorta during systole, only systole. And normally your data is the same. If it's not, you have a problem. And I have a problem in 2D, but I don't have I have a lower problem by using 4D. And that's what we have shown in our paper now. When you compare the 2D and the 4D results, the 4D results is much better compared to the 2D. And particularly in case of aortic dilatation, and particularly in case of bicuspid aortic valve stenosis.
Yeah, if I can.
Flow, sorry.
No, sorry, I didn't want to talk on top of you. Just to intervene and to complete a little bit, these kind of errors can happen because of segmentation you do when you calculate the volumes, or also what Professor Mousseaux mentioned in his last slides. You have eddy currents and mitral effects that sometimes introduce a bias in your flow calculation in the flow. And these they depend on the sequence, they depend on the parameters, and usually they are taken care of by the vendor that gives you the sequence, but you might need to look into that and have some background correction there and check these kind of things.
The background correction is the main problem, honestly. So we have worked 2 years about that for having an fully automatic system to correct the background correction. So that's the main problem from my point of view. So without any, because 1 centimeter per second difference between the stationary tissue and the real amount of velocity within the stationary tissue is a huge problem. Because when you have integration of the error in a large surface, such as the area of the mitral valve, of the mitral annulus, it's a problem. You can have a 20% difference for the flow, for the filling volume. So 1 centimeter per second difference against 0, you can have at the end 20% difference in the filling volume during all the cardiac cycle and the surface. So you have to control everything. So of course we are doing, we are experts in this field. We have done a lot of phantom studies and so on. So first of all, you need to put a phantom inside the magnet, and then you acquire it by using the ECG simulation, and you control it. You have a 0. And how is a 0 within the plane? And you will see that in 4D flow, as soon as you are far of the center, the error of the eddy current is sometimes you can have 20 centimeters per second at the upper part of your phantom, and minus 20 is in the lowest part of the phantom. So there is a problem. If you don't do the correction, you can make big mistake. But this is for when you are far of the center. So if you are using a 40 centimeter field of view, you have very accurate result in the 20 centimeters in the center. But at the border, you can do big mistakes. So you have to be aware. In 2D, it's a bit lower problem, but it can be also a problem. So of course, it's like a T1, when you are using quantification with new parameters like T1, T2, and so on, you are obliged to use some phantom to be sure to validate, to have normal values and so on. It's a bit the same for flow. You need to have healthy volunteers who can participate to research studies, or you have your own patient without any valve problem and so on. You can test your sequence 2D, 4D, and so on, and to be sure that results are compatible with the clinic. So this is all valid, because of our own validation in our center. Now we are more, and we can say to the cardiologist, okay, now you can send me the aortic valve regurgitation and so on, because I know that I am better than echo, but because we have done the job. So it takes time.
Thank you. Yes, I agree. Validation is very important. And I also think we have to conclude this webinar for tonight. So I would like to thank our speakers for their excellent lectures. And I would also like to thank the audience for their attention. And please join us again on the 12th of October for our next webinar, which will focus on imaging of Gutsch patients. And I want to like to thank you all again and wish you a great evening.
Bye.
Thank you. Bye.
Thank you. Bye-bye.